It's my pleasure to introduce a longtime colleague and friend as our speaker today, David Wilson. He's the director of the Global HIV/AIDS programs at the World Bank. Prior to this, he was the bank's lead HIV specialist. If one expects that World Bank folks are all tightly buttoned economists, it's nice to know that people like David are working in the bank and brings a lot of humanity and understanding of the epidemic. David is a native Zimbabwean. I had the pleasure of meeting him on my very first trip to Africa, Zimbabwe, in 1989 when he was a professor at the University of Zimbabwe. I recognized then that he was incredibly smart, very sharp, had a very incisive analytic mind, and has brought that to the bank. In addition, in his role at the bank, then he also has very intimate contacts with the leading agencies, including USAID, DFID of the UK, the European Union, OSAID, CETA, NORAD, and then also works intimately with UNAIDS, UNICEF, and WHO, as well as PEPFAR and the Global Fund, the major international players involved in the HIV/AIDS response. So please welcome David, and we look forward to a wonderful talk.
Thanks very much. Thanks very much. Can you hear me okay? Thanks. It's great to be here and to do this talk, and I have done an earlier version with Tom in DC and benefited from some feedback along the way. So thank you, and great to be here. I've organized this presentation on the principle of maximizing our impact and return on investment. And I use these questions to organize each section. Why should we worry? What proven interventions do we have? What could we achieve with full implementation? But what's actual implementation like? And most of all, can we invest smarter and implement better? So you'll see this simple framework throughout my talk.
Is your mic on? Is your microphone?
Am I mic'd?
This is only to the video.
Perfect. Okay, let me see what we can do. Oh, that's a light, I think. Let me try and speak up and keep nudging me if you think that I need to. See if Ashley has a solution. Okay, perfect. Okay. We'll give it just a moment. Thanks for pointing that out. Thanks, Ashley. Perfect. Is that better? Great. Thanks for letting me know up front. As I said, we'll be seeing this framework throughout my comments. Just to make the point that if we look at Chris Murray's Global Burden of Disease study, HIV has been the fastest growing cause of disease burden globally over the last 2 decades. And that's worth underscoring. It's also worth underscoring that AIDS and malaria are by far the largest causes of disease burden in sub-Saharan Africa. And 2/3 of sub-Saharan Africa's disease burden is still due to infectious diseases. And if we look at more data from Chris Murray, taking a representative country, Uganda, we see that AIDS remains by far the largest cause of disease burden. So despite our many achievements, it's still a major cause for concern. Many of us may have seen this famous Economist cover and the message, "The End of AIDS." And this was an immensely encouraging edition just before the Washington AIDS conference. And it's true that if we look at estimated national HIV incidence, the trends are encouraging. But if we look at actual measured subnational incidence, it's not over. And I'm sure many of us working in the US see similar patterns. Here is a nice UNAIDS graph showing that estimated national incidence fell by 20% from 2001 to 2011. And 39 countries, including 23 African countries, saw declines of a quarter or more. And these properly sized graphs contain the number of countries in each category. But if we turn to some of the measured subnational HIV incidences from trial cohorts, the picture is more disturbing. Take the famous Voice trial in South Africa. We have incidence of 8.8%, almost 9% among women under 25. Caprisa, KwaZulu-Natal, incidence of 7.3%. Our own study in Lesotho I'll talk about, 6% incidence. And if we look at key populations in Asia, we see incidences of 6%. So there's some encouraging trends, but the problem's still immense. When we ask ourselves, can we invest smarter for greater impact? The points I want to underscore are the importance of understanding transmission patterns, of using proven interventions for the right people in the right place at the right time. And a core distinction, which I think is still the best distinction that we can make globally when addressing HIV, between concentrated, generalized, and mixed epidemics. And we need to move away from the traditional threshold-bound 1%, 5% definitions and instead focus on transmission dynamic definitions, where quite simply, HIV epidemics are concentrated. If protecting sex workers, men having sex with men, and drug users would prevent a wider epidemic. They're concentrated if epidemics would persist even if we could protect our key populations. And they're mixed if they could be sustained by either or both transmission sources. And if we apply this definition, we see that overwhelmingly epidemics globally are concentrated, with a subset of highly generalized epidemics in Eastern and Southern Africa and of perhaps mixed epidemics in Central and West Africa. And just to underscore the importance of understanding transmission dynamics, take a country that really epitomizes diversity. Indonesia, the world's fourth largest country, over 250 million people, 20,000 islands, immense ethnic diversity. In the capital, Jakarta, a mega city of 15 million people. If we look at the transmission dynamics, we see HIV is overwhelmingly among drug users, sex workers, men having sex with men and their partners. Now move to Tanah Papua, formerly Irian Jaya, a Melanesian Pacific community in Indonesia, and we see a fundamentally different epidemic pattern. We see a much more generalized epidemic, with most transmission occurring among men and women in the general population. So really, we have the diversity of the global epidemic here in Indonesia in one country. And now turn to Cross River State in Nigeria, and look at this model using an early model to understand modes of transmission, to understand transmission dynamics. And in the old model, less than 20% of the transmission was concentrated. But in a newer, better model, we see a couple of things. We see that about half of transmission may be concentrated, but we also see that categories that we know are important in Africa, such as young women engaged in transactional sex, break out as an important category. And a quick example from India about how understanding transmission patterns can help us to fundamentally misunderstand epidemics. Here are 3 districts in India: Bagalkot in Karnataka, which has a highly generalized epidemic; Shimoga, which has a much more intermediate epidemic; and Varanasi in the north, which has a much lower epidemic. And yet, if we look at where the new infections are occurring, in Varanasi, 77% of new infections are in low-risk people in the general population, which might lead us to conclude it's a generalized epidemic. It's actually the opposite. These are all imported infections from migrant workers working in high-prevalence cities such as Bombay and then returning to Varanasi with HIV. So the models aren't enough. We need to understand the patterns behind them. Why should we worry about concentrated epidemics? And this is the simplest way of putting it. Sex worker prevalence is typically 13-fold higher than the general population, similar for men having sex with men, and drug user prevalence can be 20 to 60-fold higher. And let's use our schema and apply it to concentrated sex work epidemics. And this quite nice UNAIDS graph contrasts the red general population prevalence with the black sex worker prevalence country by country. And the bottom line is we can see sex worker prevalence is higher in most countries and far higher in some countries. And we see a 13-fold gradient on average. The good news here, I think, is that with concentrated sex work epidemics, we know what to do in the real world at scale, and we've actually checked several major sex work epidemics. And we can be quite confident about the components: behavior change communication, condoms, sexual health services, HIV testing and treatment, solidarity and group empowerment, and a focus on supportive local and national legal frameworks. So we've got a well-defined package here if we can introduce it. And I could take dozens of different examples, but here's an example from Burkina Faso, where programs, particularly in the capital, Ouagadougou, have really seen dramatic declines in HIV among sex workers, which appear to be translated into declines among antenatal women and in the general population, suggesting well-targeted programs and concentrated epidemics protect everybody. But let's turn now to what coverage is actually like. And here's the global reporting. 75% of countries either don't report sex worker coverage or report very low coverage. 91% of sex worker programs are internationally funded. And services for male sex workers and transgendered sex workers are virtually non-existent. So despite the fact we have simple interventions which are proven and which do work with sex workers, our overall coverage remains low. And this is a theme I'll return to. One of the reasons they're low is we're not investing in priority proven interventions. An example from Benin in West Africa, where sex workers are contributing 76% of HIV transmission in Cotonou, the capital, and yet receive only 0.6% of the national prevention budget. So the first step to scaling up proven interventions is to invest more in the proven, shift money from unproven or second order to priority interventions. And here's a nice comparison from Jamie Blanchard and colleagues. India has had a remarkably successful HIV program, and it's reduced HIV by approximately 70%. And it's done it through large-scale targeted interventions for sex workers, men having sex with men, and to a lesser extent, drug users. And what this simple analysis shows us is, on a district-by-district basis, we can prevent about 70 to 80% of infections in each district for roughly $500,000 a year. In contrast, a test and treat program in the same district would cost at least 10 times as much. So the point to underscore here is, where we have effective behavioral interventions, as we do in India, the big payoffs are in scaling them up, and there's a correspondingly smaller role for test and treat. This analysis would look different in high-burden sub-Saharan African countries, where we don't have well-proven behavioral interventions. But we face a problem. This is a marvelous graph from Burkina Faso, from Bobo Dioulasso, the second city. And what it shows us is how complex sex work is in much of Africa and what an implementation challenge that poses. And just look at these data. The dark red are the professional self-identifying sex workers, either CETAs, who are immobile, or roamers, who, as the name implies, are mobile. But then we've got non-self-identifying categories of people who may well sell sex: bar waitresses, mobile traders, students, and beer brewers. And the striking thing is HIV prevalence can be considerably higher in some of the non-identifying sex workers than among roamers, for example. And the point is, from an implementation point of view, it's much harder to work with people who don't self-acknowledge as sex workers. So the subtlety and complexity of the challenge means it's not as clear-cut as it may seem. But in concentrated sex work epidemics, when we ask ourselves, how can we invest smarter and do better, there's about 5 things that would make a big difference. First, better epidemic analysis and characterization of sources of transmission and geographic variation. Second, something India did well, particularly through the Gates Foundation Avahan program. Increase investment and scale up of SOP-defined, socially franchised, quality-assured sex work interventions. Strengthen real-time data for continuous program improvement. Really focus on high transmission geographic areas, and I return to this point. And in light of my previous Burkina Faso graph, develop and evaluate effective interventions for hotspots and for informal sex workers. Let's turn to concentrated epidemics of men having sex with men, using the same questions to guide us. And if we look here, we see the same pattern that we saw with sex workers, but even higher. And that is how much higher the black graphs representing HIV prevalence among MSM are than the red ones reflecting general population transmission. And let's ask ourselves about proven interventions. And I think the best summary would be, we've had some remarkable successes in the West, not least in California, and not least in San Francisco. But we've had far fewer developing country programs that have demonstrably reduced HIV among men having sex with men. And it's true, we have the Bangkok trial showing that PrEP halved HIV among men having sex with men and reduced it by 90% among the fully adherent. But the challenge is, we're not even reaching those men having sex with men in Bangkok with basic information and basic condoms outside a research context. So we're talking of scaling up PrEP before we've even scaled up simple information interventions, simple condom interventions, before we even have reliable access to communities. And that's the challenge, how to reach hidden MSM, reduce stigma, deliver at scale, and change policy. And we have to navigate between a complex challenge of a southern unwillingness to address male-male sexuality, which is getting worse in many countries, and a northern temptation to frame our response within Western constructs. So it remains a challenge. And when we look at the global coverage, we see a picture similar to sex workers. 70% of countries either don't report or report very low coverage. 90% of funding for MSM programs is international, and 19 out of 21 low and middle income countries reporting are wholly reliant on external financing for programs for men having sex with men. So the real world picture is disturbing. And just look at this. Very few graphs speak as powerfully as this. These are men having sex with men reached by any, repeat, any prevention services. And we see rates of 25% in the Caribbean and approximately 10% in Africa. So we really do have a mountain to scale still. Let's turn to injecting drug users quickly and ask ourselves these questions. Showing the same graph, even more extreme. And we see rates at least 20-fold and up to 60-fold higher. And when we ask ourselves whether we have proven interventions, we actually do have 3 proven interventions: needle syringe programs, opioid substitution therapy where we face opioid epidemics, and antiretroviral treatment. And let's look quickly at the evidence for each of these. NSP, we have evidence from the famous McDonald et al. 99 city study, an ecological study showing a 20% decline in HIV per year in cities with NSP programs, and a 10% increase each year in cities without. OST is by some definitions the most evaluated public health intervention we have. We have the RCTs, we have the observational studies, we have Cochrane reviews, we have the famous Amsterdam cohort, and we got the recent BMJ meta-analysis. So the evidence is clear here. Turning to implementation, we see the same picture, but even more strikingly. 86% of countries either don't report or report very low coverage of NSP programs. And the average number of syringes distributed globally per injecting drug user is less than 3 per year. And just look at this. Look how low access to basic services is. 90% of injectors have no access to needle syringe programs, 92% have no access to opioid substitution therapy, and 85% have no access to AIDS treatment. So the theme that I'm emphasizing again and again is the real challenge before us is implementation. In varying degrees, we have proven approaches. Our ability to scale up and to implement those proven approaches is the biggest constraint to even envisioning an end to AIDS. And now let's turn to generalized epidemics, which can be very perplexing, and ask ourselves the same question. And Tom will tell you so much of our prevention in sub-Saharan Africa before treatment resembled this graph. And let's ask ourselves why they're so different. And when I worked in Southern Africa, I was part of a program, a regional program, which tried to map and count sex workers throughout Southern Africa, including sex workers in Swaziland and Lesotho. And as hard as we tried, we found almost none. What did we conclude? Well, we concluded they must be very hidden, and we looked even harder. Luckily, before we had done that too much, this FHI behavioral survey came out. And the bottom line it told us is a lot of our traditional risk groups, security guards, drivers, soldiers, police, and seasonal workers, are having a lot of casual sex, but they're not having formal commercial sex. Now, that casual sex may in varying degrees be transactional, but it's almost certainly not with self-acknowledged, self-identifying sex workers. So we have a very different epidemic pattern to India, for example. And look at this very nice modes of transmission study from KwaZulu-Natal, the highest prevalence state, subnational entity in the world, in South Africa. And what this graph shows us, and we've used the varying degrees of orange to code it, is 76% of all infections in KwaZulu-Natal are in the general heterosexual population. So we're not going to stop HIV unless we can stop it in the general heterosexual population. Targeted programs for sex workers and men having sex with men may prevent a fraction of the infections, but the core challenge is in the general population. And just look at this. This is very hard to credit. This is from Swaziland's SHIMS. It's the world's first national population-based household door-to-door HIV incidence survey. And here are the prevalence data. This is a highly representative national survey. Just look at women aged 30 to 34, 55% HIV positive, and a wholly random population-based sample. Almost 50% of men and women aged 35 to 39. So fundamentally different to the concentrated epidemics we looked at. Now, we turn to the vexed question, do we have proven approaches for generalized epidemics? And this is an update of a famous table which looks at all the RCTs with HIV, or in a few cases, STI endpoints. And it looks at completed, stopped, and the number that were effective. And if you look at the shading, we see the light shading here, which depicts an early generation of almost wholly unsuccessful trials. We had one successful STI treatment trial in Mwanza in Tanzania, subsequently negated by 6 unsuccessful trials. Then we start to move into the dark terrain, and we see some striking things. First, we see 3 out of 3 male circumcision trials prevented male acquisition of HIV by at least 66% and perhaps higher. We see pretty consistent results for ART-based prevention, whether treatment is prevention or whether PrEP. And then I'm going to look at some slightly weaker, but still suggestive World Bank studies looking at cash transfers, social payments for HIV prevention. And each of those appears to have been successful. So if we were to sum up what this chart looks like, what it would say to us is traditional behavioral prevention has been disappointing in generalized epidemics. It appears to be the biomedical and just possibly the economic interventions which may make a difference. Now let's turn to the question of, do we have proven approaches at scale? And this is voluntary male medical circumcision with a clinical efficacy of at least 60%. But all the long-term studies in Kenya, Uganda, and South Africa are showing the longer-term population level effectiveness is probably even higher. And there are good reasons why that's the case. And here's a study we did in South Africa with the government to look at the importance of investing in circumcision. The bottom line is, if we circumcise men at the peak age of 20, all our investments in male circumcision amortize or pay for themselves in just 7 years. Very few public health interventions pay for themselves in as short a period as that. Bearing in mind that we take 5 to 10 years to even develop HIV, AIDS, illness, the point at which costs start to accrue. And this is the problem. We know that circumcision is efficacious in trials and effective at the population level. But look at actual implementation. It's off track. At the halfway mark, and these data are now 6 months out of date, only 3 million out of a targeted 21 million people, or 14%, and a total of 26 million required people, 11% have been circumcised. So again, the challenge is implementation. We have proven approaches, we're not delivering them. And the challenge with circumcision is demand. In many countries, we have more suppliers and more services than we have demand for. Now let's turn to TASP, treatment as prevention. This is really important and really challenging because there's an immense and understandable global movement to end HIV through treatment as prevention. And if we look at the clinical efficacy of TASP, it's actually close to 100% because the 96% had a misclassified transmission episode. Adjusting for that, it was 100% in ideal circumstances. But the real-world effectiveness seems to be lower. We've got a study from Hlabisa Matubatuba in KwaZulu-Natal from Frank Tanza and colleagues showing that HIV was 34% lower in areas of 30 to 40% ART coverage, which appeared to be the saturation point, than areas of 10% coverage. We have a Chinese discordant couple study showing HIV 26% lower in discordant couples who were infected by transfusion or sexual transmission, but no protective effect for IDU indexes. We have one study from Uganda, Burungi et al., showing no effect. My colleague David Wilson in Sydney points out that in Australia, virtually all men having sex with men are tested, quickly referred to treatment, and yet we see incidence continue to rise. And Sydney is not alone in that respect. We see similar figures for many Western cities. And finally, Swaziland. I talked about Swaziland SHIMS, their national incidence study. This is the disturbing part. 85% of Swaziland's population are on treatment at CD 350. And yet Swaziland still has a measured annual HIV incidence of 2.4% on top of a 26% adult prevalence. And the point is, if we had modeled it 20 years ago, we would have said overall adult prevalence could never get to 26%, and incidence could never stay at 2.4% on top of that prevalence. And yet, with nearly full treatment, we still have these figures. That has to be a bit worrying for the real-world effectiveness of treatment as prevention. And we have at least 4 studies in the field looking at the population-level effectiveness as treatment as prevention. And I'll leave this summary for you to look at in the slides, but I won't go through it in detail now. Suffice it to say, these 4 studies are trying to answer the long-term population-level effectiveness of TASP. But they're going to take 5 to 7 years to do that. And we're going to need to make decisions and invest money before that. Now, what would full-scale implementation of treatment as prevention look like? Let's go through the cascade together. We currently, after an immense global effort, an unprecedented global effort, have 10 million people on treatment. But 26 million people would be eligible at CD 500. And 32 million would be eligible under test and treat. So to reach CD 500 would mean increasing our program 2.5-fold, and reaching test and treat would mean increasing global treatment over 3-fold. And when we consider the immense effort that went into one PEPFAR, into one global treatment surge, redoubling that and redoubling it again is a challenge. And then we look at what actual implementation is like, and many of you will be familiar with this famous CDC depiction of the US treatment cascade presented at the last CROI meeting. What it shows is, of all Americans who are HIV positive, 28% reach the end of the cascade being successfully virally suppressed. In West Africa, it's lower. only 10% of all West Africans who are HIV positive are virally suppressed. Look at retention. And this is striking. I think colleagues in this room are going to Malawi soon. And you'll know what immense international support Malawi's treatment program has had. It's striking, though, that fewer than 60% of Malawians are retained in treatment programs after 5 years. In Indonesia, which has less international assistance, fewer than 50% are retained in programs. So even retention is a challenge. And then take viral load. This graph has both good news and bad news. The good news is, if we are on ART, only 30% of us are virally infectious. At least 1,500 copies or more. But if we're not on treatment, 74% of us are infectious at this level. So the good news is 30% is a lot better than 74%. The bad news is 34% unsuccessfully suppressed, 30% unsuccessfully suppressed is still pretty high if we're looking at the population level implementation of treatment as prevention. And these data are from Cape Town, South Africa, one of the richest cities with one of the best HIV implementation rates in Africa. And we know drug resistance is a problem. And what this suggests is 20% of the population get acquired drug resistance after just 3 years. And here's a really nice map showing the challenges of drug resistance in ART-naive populations. Now, cost effectiveness of treatment as prevention. Till Barninghausen and colleagues from Harvard and Hlabisa in South Africa looked closely at the cost effectiveness of treatment for treatment's sake, male circumcision, and TASP. And all of them are cost effective at a generous WHO rule of 3 times per capita spending. But what Till found is you could achieve significant savings through optimal intervention mixes without compromising either prevention or mortality. So you could save money and not have worse prevention or worse treatment outcomes. And what he essentially found is high ART and male circumcision coverage led to a similar incidence reduction as TASP. But it did it for $5 billion less than TASP in South Africa. And he found that increasing male circumcision at $1,000 per infection averted outperformed ART at almost $7,000 and TASP at $8,500 per infection averted. And so their most cost-effective prevention and mortality scenario was an urgent focus on MC alongside ART, and reaching 50% ART coverage and 60% male circumcision coverage proved optimal. And he made the very good point that as only half of people in South Africa who need treatment at CD4 350 and above received it, increasing treatment in this group should precede treatment expansion to earlier disease stages. In other words, we haven't even reached people at the CD 350 threshold. Build up towards that threshold rather than capturing people with earlier disease stages. Let's turn briefly to financial incentives. And we have 3 World Bank randomized controlled trials showing how cash transfers reduced STI and HIV transmission. And cash transfers have a growing evidence base in health and education. And some of the most famous examples were in Mexico and Brazil, where in Mexico, the Mexico government used the Progressa program to provide cash transfers to poor households in return for having children attend antenatal screening, immunization, and school. And they found big poverty and big health and education impacts. And we've now looked at this in relation to HIV. And in Tanzania, I think this is the weakest of the 3 trials. People who were offered up to $60 annually to stay STI-free had a 25% lower STI prevalence. But in Malawi, in Zomba, in southern Malawi, and this is the most exciting study, girls and parents who are offered up to $15 monthly to stay in school had a 60% lower HIV prevalence, whether they stayed in school or not. So just giving girls a bit of money, ideally to stay in school, but whether they actually went to school or not, reduced HIV by more than half. And this appears to be because they were able to choose younger partners. We were able to measure that, and they were able to make more prudent choices about their partners. And the interesting thing in Malawi is this trial wasn't even an HIV trial. It began as an education trial, and we added an HIV component to it. So the point to make is when we look at cash transfers in Malawi, we're not simply doing it for HIV. We're doing it to keep girls in school. We're doing it to reduce teenage pregnancy. We're doing it to reduce early marriage. We're doing it to reduce other sexually transmitted infections, and we're doing it to prevent HIV. And then we have another study in Lesotho where adolescents offered a lottery ticket to win up to $50 or $100 every 4 months if they stayed STI or HIV free, had a 25% lower HIV incidence, which was 33% lower among girls and 30% lower in the high value arm. And economists like lotteries because you can maximize the benefits while minimizing the resources. So the bottom line is 3 out of 3 trials have shown that either incentives or income support can reduce HIV transmission. And we've started to look at some formulas for how countries could actually finance these incentives, not simply from the HIV budget or simply from the health budget, but from health, education, social development budgets. And here's a summary of the studies. And again, they're in the slides for people who'd like to look at them. And here's a summary of the actual effect sizes for referral later. But here's the graph I really like from Charlotte Watson, her colleagues in London. And the bottom line is cash transfers reduce school dropouts by 1/3, early marriages by 40%, HSV2 by 76%, teen pregnancy by 1/3, and HIV by 2/3. Pretty good package for $15 a month. But this is the question I pose, and we're actually organizing a meeting in Southern Africa with ministers of health and social policy in April. Is this evidence robust enough? And are financial incentives really scalable, affordable, and durable? In other words, what happens when they're withdrawn? We have some interesting real-life data from a very nice paper published by Lucy Kluwer of Oxford University in Nature. And she looked at the fact that South Africa actually raised the eligibility age for girls to continue to receive payment for children, child support grants. And she has some nice observational data that increasing the age of eligibility increases the HIV prevention benefit. So the good news is that's further evidence that it works. The bad news is it does pose indirect questions about durability. And I think the really exciting opportunity is we're not saying that countries should do social protection and social welfare programs just for HIV, but we're saying where countries have social welfare programs, such as South Africa, how can we tweak or adopt them to maximize the HIV prevention benefit? And this work and Lucy Kluwer's work suggests that's possible. Now, I'm just going to move towards the final part of my talk, and I'm just going to highlight something that's really dominating HIV analysis now, and that's the conviction that through better targeting, better geographic prioritization, we can come much closer to ending HIV. And this is something that UNAIDS's new report will be focused on. It's something that Debbie Birx at CDC, who will be the new PEPFAR ambassador, is very invested in. It's something Mark Dybel believes will help us to end HIV. So there will be another grand convergence around this issue. Better geographic targeting and hotspots analysis. So let's ask ourselves how far it might take us. And Indonesia is a great example. I showed you the data earlier. Half of Indonesia's HIV is historically in Papua, which has less than 2% of the population. So there's a clear geographic proposition there. In fact, much of Indonesia's epidemic is Papua and the mega island of Java, which has 100 million people, about 38% of Indonesia's population. Philippines is an even better case. 43% of all HIV is among MSM in Metro Manila, and 75% almost is MSM in just 3 cities. Metro Manila, Colombo across the bay, and Cebu, the maritime center in the middle. So clearly, for the Philippines, you could dramatically reduce HIV through better geographic targeting. India, the most successful HIV prevention program globally. We know that over 75% of their epidemic was traditionally in 4 out of 35 high-burden states in the south and the west. They targeted them, and they succeeded. Thailand, we know that 70% of all Thailand's infections are in just 33 provinces, dominated by Bangkok, which contributes a third. And here's a really nice graph from Jamie Blanchard in Pakistan, where 70% of Pakistan's IDUs are in just 4 cities, dominated by Karachi in Sindh. And Kenya, we have a nice piece of data from Kenya. And the bottom line here is 54% of Kenya's new infections are in just 9 high-burden counties. And there are the counties. They're nearly all in Nyanza in the west. But the other good news is less than 2% of new infections are in the 8 lowest burden counties. And our analysis suggests you could actually increase the impact of Kenya's program by 20% without adding an additional dollar if you targeted better. Look at South Africa. South Africa has more incidence studies than anywhere. And what this graph shows us is how high incidence is in certain geographic areas and subpopulations, leading us to think we could target better in South Africa too. And here's an analysis by, in fact, a medical geographer, Frank Tanza, from Hlabisa Matuba, which shows how HIV incidence in their district is geographically concentrated. And that concentration is even greater when we look at it per square mile, with this cone representing the concentration peak. So this is pretty encouraging. But now we have another study from Laith Abu Radad, nuclear physicist turned theoretical epidemiologist and modeler. And they looked at spatial clustering in all the DHSs where you had both HIV prevalence and, importantly, GPS coordinates. And you need those for this analysis. And this is probably the most important study of clustering. What it shows us is there's tremendous spatial variation with valleys of high prevalence, dams which block transmission, and islands of either very high or very low prevalence. Now, this is the cautionary figure. 14% live in high prevalence clusters and 16% in low prevalence clusters. But the average masks a lot of subnational variation. And the bottom line is there's much more clustering in low prevalence and concentrated epidemics. It was highest in Senegal, but also high in Burkina Faso, DRC, Sierra Leone, and Ethiopia. But there's far less clustering in the highly generalized, diffused Southern African epidemics. There was none in Swaziland, virtually none in Zambia, and virtually none in Lesotho. So the bottom line is geographic targeting appears to be more effective in concentrated epidemics than in highly generalized ones. And here's a summary of what we know. First, there's obviously a major opportunity for better geographic targeting in big diverse countries like India, Indonesia, or Nigeria, but we knew that. There's significant opportunity for better hotspot targeting, especially in concentrated epidemics. There's a big opportunity for detargeting low transmission areas, Kenya, for example. Even more strikingly, Ethiopia. When the first EDHS, the Ethiopian Demographic and Health Survey, came out, we revised our estimates of Ethiopia's HIV epidemic downward. And the striking thing is there's virtually no HIV in the Great Southern Rift Valley. So you can detarget those areas and concentrate on priority areas. But we really do need a rigorous test, and not just cheerleading, of the feasibility and utility of hotspot targeting. In other words, are we talking of an 80-20 rule? Could we actually, the 80-20 rule, get 80% of our yield for 20% of our sites? Or is it closer to a 55-45 rule? In other words, some concentration, but not enough to fundamentally transform the picture. And that's going to be the key question. I'd like to turn finally to resources and their implications. We do see HIV resources have started to stagnate and fall, and we do see a significant funding gap. And if we look beyond HIV to overall development assistance, it fell for the first time in a generation in 2011 by 2%, then 4% in 2012. So we have seen HIV, international development assistance for all development, decline in the wake of the economic crisis. And look at South Africa. This is remarkable. South Africa's AIDS budget grew 500% in a decade to almost 2 billion, the second largest in the world after the US. This is the really striking figure. From the finance minister's own budget speech, Pravin Gordhan's own budget speech, AIDS will be 38%, almost 40% of South Africa's health budget next year. And that's extraordinary. That's just unprecedented. And it's not as if South Africa's budget's in surplus. You can see here that South Africa has a structural budget deficit. It started to narrow it a bit, but it's not going away. And I always like to present this graph. I don't know whether people have been following the post-MDG consultations on what will replace the MDGs or Millennium Development Goals. But here's the high-level panel report, and here's a word cloud, which sizes objects by the number of citations they get. You can see we're in a very different world to the MDGs of a decade ago. The focus now is poverty elimination, partnerships, growth, access to markets, energy, accountability, vision, business. Even education is big. But I've highlighted health there to make it easier for us to look for it. It's declined in importance relative to the MDGs, and HIV doesn't even appear here in its own right. So we are moving into a world where people perceive other problems, and that's going to be an issue. So let me sum up, and then we could discuss any points that arise. I think we face an, at best, flat financing environment, and we face competing priorities, powerfully illustrated by the word cloud. With our existing implementation and rate of expansion in implementation, we're unlikely to prevent more than half of the new infections over the next decade. With full implementation, we could easily prevent over half and perhaps 3/4 of more of new HIV infections. But bridging the gap between full and actual implementation is a tremendous challenge. When we talk about implementing treatment as prevention, for example, it's not a question of advocacy, it's a question of painstaking, ground-level, coalface work, patient by patient, to raise CD4 inception levels. And South Africa is a great example. 3 years ago, they had a national testing campaign where they tried to test everybody in polling stations. And then they raised the threshold of eligibility from 200 to 350. The actual measured CD4 inception levels didn't change one iota. So declarations don't change implementation. It's the painstaking work of implementing that does so. And finally, I agree with something Bill Gates says again and again, is that we can't even talk of ending AIDS without more and better tools. It's really hard for us to even end diseases for which we have good vaccines, let alone end AIDS with the tools that we now have. Thank you.